Welcome back to The Explainer. You know that peripheral vascular exam station in your OSCEs? The one that always feels a bit stressful? Well, today, we're going to break it down into a super clear, high-scoring routine that you can absolutely master.
Right. Picture this. You've got 8 minutes. The patient has leg pain. Where do you even start? It's that classic scenario, right? The clock's ticking, pressure's on. Look, the key isn't just knowing the steps. It's having a slick, systematic approach. So let's build that structure right now.
So here's our game plan. We're going to walk through 6 key stages: entry and consent, inspection and upper limbs, the abdominal and femoral exam, the lower limb exam, some key special tests, and finally, how to present your findings in follow-up. This is literally the exact flow you'll want on the day.
All right, first up, entry, introduction, and consent. This is all about setting the stage for success. Those first moments are absolutely crucial. Okay, these 5 steps, they are non-negotiable. Seriously. First, wash your hands, always. Then, introduce yourself and confirm the patient's details, just to be safe. A great way to start is with an open question, something like, "So, what brought you in today?" It just builds that instant rapport. And then you've got to explain what you're going to do, examine their blood vessels to get that all-important informed consent. And of course, always offer a chaperone.
And, what's really cool about this part is how simple things make a huge difference. Just offering a blanket or only exposing the area you're examining. It's all about patient dignity. It shows respect, it builds trust, and honestly, it just makes the whole thing go so much smoother for both of you. A simple phrase like, "I need to examine your abdomen now. Is that okay?" works wonders.
Okay, section 2, inspection and upper limbs. This is where the examination really begins. We're going to start with a general look from the end of the bed and then move in closer to the hands. So before you even touch the patient, your exam has already started. Just from the end of the bed, what do you see? Do they look well? Unwell? Are there any walking aids nearby? That could be a huge clue, maybe suggesting claudication or pain when they walk. These little details can start building your differential diagnosis from the get-go. All right, now let's get hands-on. You're basically hunting for the classic signs of peripheral vascular disease. Think about it. Poor blood flow means less oxygen and nutrients, right? So you're looking for things like skin ulcers, hair loss, maybe even amputated digits. You'll also check for that bluish tint, peripheral cyanosis. Feel the skin temperature and then do a quick capillary refill check on the nails. Should be less than 2 seconds.
Okay, trying to remember all the pulses in order when you're under pressure, it's tough. So here's a mnemonic that will be your best friend. Can big rabbits find pretty pink dandelions? It stands for carotid, brachial, radial, femoral, popliteal, posterior tibial, and dorsalis pedis. It's a lifesaver, trust me. It makes sure you don't miss a single one as you work your way down the body.
Now here's a pro move that'll really impress your examiner. First, feel both radial pulses at the same time. If you feel a delay between them, that's a radial-radial delay. It could point to something like subclavian artery stenosis. Next, compare the radial pulse to the femoral pulse. A delay there? That's the classic radiofemoral delay, a huge red flag for coarctation of the aorta. This is a great check to show you know your stuff.
All right, next up, we're moving to the middle for the abdominal and femoral exam. Assessing the central vessels is key here, and checking for an abdominal aortic aneurysm, a AAA, is something you absolutely cannot miss. So, before you go pressing on someone's belly, communication is everything. Just saying something simple like, "I'm going to gently press on your abdomen now. It might be a bit uncomfortable, but please let me know if you feel any pain." It prepares them, it reassures them, and it makes it clear that they can speak up. That's vital for their comfort and for your assessment.
Okay, so the AAA check. First, just look. See any obvious pulsations? Then you're going to gently but firmly press into that epigastric area. Now here's the key. You're not just feeling for a pulse, you're feeling for an expansile mass. That means it pushes your fingers outwards with each beat. That's the sign. After that, you'll check the femoral pulses on both sides and have a listen with your stethoscope for any bruits, those whooshing sounds that mean turbulent blood flow.
All right, moving on down to the lower limb examination. We're going from the groin to the toes, and this is where you'll often find the most obvious signs of vascular disease. The popliteal pulse. This one is famously tricky to find. The secret? Have the patient bend their knee to about 30 degrees. This relaxes everything and lets you get your fingers deep into that popliteal fossa. And here's a great clinical tip for you. A normal popliteal pulse is actually kind of faint. If it's super easy to feel, that should make you suspicious of an aneurysm.
So now, you're basically going to repeat the same inspection you did on the hands, but on the lower limbs. You're looking for those same things: ulcers, hair loss, weird color changes. And definitely don't forget to check the skin temp and the cap refill on the toes. A huge tip here: inspect between the toes. That's a classic hiding spot for ulcers. And wrap it up with a quick sensation check, because poor blood flow can mess with the nerves too. Okay, Section 5, Key Special Tests. Now, if you have time at the end, doing one of these is how you can really impress the examiner. It shows you're not just a robot following a checklist, you're thinking clinically. And my top recommendation? The Berger test. It is perfect for OSCEs. Why? Because it's a dynamic test that gives you really clear visual results for peripheral arterial insufficiency. Let's walk through exactly how to do it. So here's what's happening. First, just look at the color of the patient's soles. They should be pink. Then you lift both legs up to 45 degrees for a minute or two. If there's poor circulation, the feet will go pale. That's a positive sign. Then have the patient sit up and hang their legs down. What you'll see is this mottled, deep red color as blood rushes back into those oxygen-starved tissues. That's called reactive hyperemia, and it's a really powerful visual sign of ischemia. Now, you're probably not going to have time to actually do an ankle brachial pressure index or ABPI in an OSCE, but you should absolutely say that you would want to do one, and you need to be ready to interpret the numbers if they ask. Basically, normal is around 0.9 to 1.3. Anything below 0.9 suggests some level of disease, and if you see a value under 0.5, that's severe critical ischemia.
And finally, let's talk about finishing up the station, presenting your findings, and outlining your follow-up plan. This is how you bring it all home.
Okay, so after you thank the patient, you need to tell the examiner your plan. This always includes more investigations. You'll want to mention some baseline bloods, to check for things like high cholesterol or diabetes. An ECG is also key, maybe to look for AFib. An echo could be useful too. But the big one you have to mention is a duplex arterial ultrasound of the lower limbs. That's what will actually let you see the blood flow and find any blockages.
And to finish it all off, you suggest your referrals. For most of these patients, that's going to be a referral to vascular surgery. But keep your thinking broad. If you suspect some kind of inflammatory cause, maybe a connective tissue disease, then a referral to rheumatology would be a really smart suggestion. So, back to that question. What's the single most critical sign you should never, ever miss? Well, while a lot of these signs are important, if a patient tells you they have severe pain in their foot at rest, especially at night, that's rest pain. It is a massive red flag. It's the hallmark of critical limb ischemia, and it's something you just cannot miss. So there you have it. By following this whole sequence from the introduction all the way to your investigation plan, you're not just running through steps. You're showing that you're a safe, thorough, and competent clinician. You're ready to nail this station.